Hello, everybody. Welcome to another edition of the AFR EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue. Today I'm joined by the Dr. Kim Pruitt, our Medical Director.
Hi, Chief.
Hello, Doc. And we're also joined by Lieutenant Chuck Demas.
Hey, Chief.
From the 69th Cadet class, my fellow classmate.
Yes, sir.
Longtime friend. Thank you, dude, for coming out and talking to us about this call. This was a super unique case. This was an unconscious inhalation patient that was secondary to a car fire. So I know you all, as Rescue 20, weren't on the initial dispatch because the assumption it was just a car fire kind of out in a remote area.
Yes.
Where Engine 20 responded to initially. So talk with us a little bit about how that call developed and how you became involved in it.
All right. So the call came in probably 15 minutes, 20 minutes earlier, something like that. I didn't keep track of time. The pumper had been dispatched to it. They were gone. And then as the rescue, we got dispatched a little bit later to the car fire, 71 Delta. And I figured if they were calling for us, that there was something going on more serious than just asking for a 55. We get to the truck. It shows that 55 is level 0. So I'm like, okay, let's buckle in. This is gonna be fun. And it just raised my index suspicion that, this person may have had serious burn injuries and that type of thing. So just started running through the things that I might need to do on my way there. And on the way there, as we were listening to the radio traffic, I got to give Justin Mesh was there on an overtime. He was a captain at the time. He's a chief now, so congratulations to him. But he did a phenomenal job. The guys got the fire knocked down. They pulled the patient out and were treating him before we got there. But he actually called for the Cyanokit while they were pulling him out and stuff like that. So the Cyanokit was already on the way before I was en route. And Battalion 2 was out and about and heard the call and actually jumped the call and brought it to us. So shortly after we arrived on scene, he arrived on scene with Cyanokit. So it was actually amazing. So kudos. This is the part where I get to sing everybody else's praises. They set me up for success. So it made my job easy.
Yeah, huge kudos to Battalion 2 to monitoring that and then knowing they have the equipment and getting it to him quickly. That probably was the ultimate lifesaver for that patient, indeed. So Engine 20 was able to put out the fire. It sounds like they did find a 51-year-old male who was inside and it was initially unresponsive. It sounds like the initial reports that may have been living in the car and potentially was trying to cook inside the car, something to that effect led to the fire.
It was it was an interesting call. You get to the call, they've got a patient laying down on the floor. You see kind of the car's full of just a lot of junk. Of course, most of it's burned by now, but you could tell that it was just full of stuff. So we're like, okay, guy was living in the car, and we did find out later he was trying to cook pancakes in the car. Suspected that the guys were, when we pulled up, I see the guys bagging him. I'm like, oh no, we're running a code. Okay, this is a code. So I run out, get ready to grab all my stuff. Think I know I'm going to be running a code. Walk up, they're bagging him, and he's breathing kind of agonally. Color's actually surprisingly good. I'm like, okay. I was like, okay, why is this guy not awake? What's going on with this guy? Because I know if I'm burned the way he was and that kind of thing, I'd be screaming in pain, not happy. Start looking at him. Airway looks pretty good. Stuff like that. The lighting's bad, and even though there's no lighting, I see that his pupils are pinpoint. So at that point in time, I suspect that he was overdosed. So from there, we still were treating this more as the burn. The burn is the most important part, so we start treating it as more of the burn and the trauma and that type of stuff. So we start loading him up, getting him into the truck.
And he's minimally responsive at that time and still kind of bucking it. And it sounds like some soot you noticed around the mouth, airways, a little bit swollen on the tongue, but otherwise a patent airway.
Yes. I'm so thankful for that. And I think actually to some degree his decreased respiratory rate kind of saved him. If he's breathing faster while everything was burning, I think his airway would have been in a much worse shape.
Yeah.
So we got him in the back of the truck. He was still maybe responsive to pain, mostly unconscious. So I wanted to give him a little bit of Narcan to increase his respiratory rate while we're trying to take care of everything else. And Jonah starts working in IV, so that way we can hang the Cyanokit and that type of stuff. I actually decided to give less Narcan than normal. We had Jonah give him 0.25, just because it's easier instead of just 0.2, the half dose, because I didn't want the patient to wake fully up. I just wanted to bring his respiratory rate up enough, and burns hurt, but at the same time with him already having narcotics on board, I didn't want to I didn't want to be trying to give him fentanyl to control his pain after I gave him a full dose of Narcan. So I was just trying to dance that fine line.
It's fantastic. Good thinking on that. Doc, burn victims, obviously this is a unique case where we're pulling them out of a car, but it is relevant as we do see this happen quite often where folks are living either in encampments or they're living in cars because they're experiencing homelessness. But our typical case is maybe pulling a patient out of a structure fire, right? But why is airway the most important assessment when we're dealing with burn victims?
So airway, especially in burn victims, the heat, and I love your point about it hadn't even crossed my mind, but the fact that maybe he had a little bit of respiratory depression before the fire happened probably saved him. That heat, whether it's steam or just heat or fire, actually can cause profound swelling in the back of the throat and in the airway, and that tends to just get progressively worse. And so clues that you have airway involvement, like you looked for and like you documented expertly, is any soot around the mouth, on the tongue, even singed eyebrows or singed facial hair suggests that that face was close enough to flames to really be concerned about potential swelling. And then if they're still talking to you, changes in their voice, normal kind of stridorous sounds, things like that, that would suggest an impending airway closure, and that can happen fast after pulling someone out of a burn. And this is one of those instances. We don't like to think about it, but this is one of those textbook instances where if that airway does close, you need to have a crike kind of very immediately reviewed in your head before you might find yourself doing that in this instance.
And yeah, I definitely was actually looking up the protocols on CREC on the way to this call, just because, like I said, we got this late and that kind of thing. So I knew that they're asking for the rescue, not just a 55. I like I said, I had a higher index of suspicion. I was like, okay, are we gonna crack this guy? How bad is it? Burns? That type of thing, or am I gonna have to intubate him? That kind of thing. So I was, like I said, I was really lucky. I haven't had to crack yet in my career, and I'd be happy to go my entire career without it. But at the same time, being ready to if you have to.
Yeah, and it's always, if you're at the point where they're unconscious and unresponsive, it's okay to take a look and try to intubate from above. Just recognize that anatomy, it may be sooty, like not familiar, and then swollen too. So moving to a crike quickly, and the indications for a crike being can't oxygenate, can't ventilate. And it sounds like this guy, even though he was breathing slowly, was still ventilating.
Yeah, his airway maintained the whole way, which was so nice. He actually started arguing, saying, his car wasn't on fire, and that kind of thing. He couldn't leave his car, and I felt bad for him, but at the same time, he had so much soot around his nose and mouth, pretty obviously marked. So I did definitely watch that in his lung sounds the entire way in, just because you want to make sure you don't have trouble with the airway. Very fortunate gentleman, this guy. And one of the things when we were mixing the Cyanokit on scene, like I said, Chief was really awesome jumping the call. Mesh was great about calling for it early, that kind of thing. Pipeman brought me the whole setup as I was sitting there trying to fill it. The spike wasn't there, so I'm like, because sometimes it falls out of the box because it's just a box, and when it gets jostled around, stuff falls out. So the spike wasn't there so make sure you have everything before you leave scene. And we were still just setting stuff up, so I was able to go, hey, go back and check the cooler for the spike. I need the spike. The guys brought it back to me. I was able to reconstitute it. And the other thing is, if the solution in the Chief's box is expired, you can always just use your 1 liter cc bag. It has a nice little fill line on it. You just fill to the fill line and just gently shake it, and you're good to go.
It's awesome. Yeah.
So just to recap, the actual Cyanokit is just on the battalion chief vehicles, right, and on the 7-8 vehicle, and it's a powder.
The squads as well.
Squad has it too, and then it's a powder, so you just have to reconstitute it, and you can use any normal saline. Ideally, what's in the container with it, but a liter will work fine because there's that fill line marked.
Yes.
Okay, and it turns bright pink, right?
It's got like a pinkish reddish.
Yeah.
Yeah.
And don't shake it.
No,
It's
just a
easy.
gentle rock.
Okay.
And I think that's a key point is just, it's a perishable skill because we don't do it that often, but it's almost always needed and prevalent, especially with burn victims like we talked about. So I think even though we don't have it on our frontline apparatuses, tying in with your battalion chiefs and, hey, let me look at that, get with the 7A, they have the trainers, they can bring them down and check them out. So that was great that you were able to do that quickly and efficiently. So that's kudos to you. In terms of the other treatment for the patient, we talked about roughly first and second degree burns on the arms and chest. I think you estimated about 10% body in total. We took care of the Cyanokit early to really treat his life threat. We were out on the Airway. Any other treatments that you guys provided while you guys were en route?
Just the oxygen. We had a non-rebreather on him. The Cyanokit. One of the things that I've done with the past, like with the pediatric that we talked about, a burn patient here, is I could have covered him with a blanket, and I didn't at that time just because I was looking at everything and just trying to get stuff done on the way to the hospital. But in his case, since he was 10% or more, it's going to be a dry sheet. You're not going to wet it or anything like that. You don't want him getting cold. And it was, when this came in, it was, I think, it was still cold out. So it was one of those things I didn't want to make. You don't want to make that kind of patient hypothermic, but at the same time, you don't want the burns to get worse.
Yeah, I think it's great that Chief Mesh was thinking about the Cyanokit early, because we know that burning synthetic materials is what causes that poisoning, and we think about it in structure fires all the time, and we know it's kind of a given. But with these car fires, with the burning synthetic materials in the cars, he likely had a very significant cyanide exposure, which could have been also contributing to his altered mental status. But what you're looking for is an altered patient. They may be tachycardic. You're not going to be able to base that decision on their oxygen level necessarily. So the Cyanokit was an important move here. I think that really made a difference for him.
And I think you guys followed up and you guys sent back that he had a CO level of 20?
Yeah, which is critically high as well. So that's another good talking point here, is that when you have that burning synthetic material, not only do we need to be thinking about cyanide toxicity and giving the Cyanokit, but also high flow oxygen, because many times, most of the time, there will also be a concomitant carbon monoxide poisoning as well, which also won't have many clues. Like the oxygen saturation may be the same, but it's still poisoning in the blood, and high flow oxygen is the key there too. So he definitely had a CO level that was 20 times higher than it should be, and then also his lactate was very high at the hospital, which also suggests the cyanide toxicity as well. So your treatments were spot on.
Talk to us a little bit, Doc, about the way for us to estimate. We talked about the Palmer method and knowing what the BSA is, so the percentages. So what's a good way to do that?
So we used to learn the rule of nines, and I can never remember, and I still have to look it up. And then they came up with this Palmer method, and you use the patient's palm, and their palm will be 1% of their body surface area. So if you can just kind of eyeball about how much that would be, I find it a lot easier to add, especially since burns tend to be a little irregular and not always involve like the whole arm or the whole leg. The palm is a nice, I think, adjustment for that. So the 1% for the patient's palm.
1% for the patient's palm, got it. And then these patients are pretty much always going to the trauma center, is that correct?
Yes. Severe burn patients, I'd say, I don't want to quote, I may be wrong, so don't hold me to this, but in the guideline, I think probably over 5 or 6% need to go to the burn center. And especially important for burns, anything to the face, circumferential around the hands, GI or GU burns in particular, those are higher risk burns that need the burn center as well. But I think we're safe with any, especially flames. Thermal burns need to go to the trauma center. Sometimes hot water burns can be handled at the other ERs, the smaller ones. But
interesting case. Tons of experience, obviously, that you've been in the system for really a long time, both here and I think Albuquerque Ambulance back in the day. So you've seen a lot, been able to do a lot, except for Craig. That's still coming.
No. Thank you, but no.
Just looking back on this call now, any information that you want to share with newer providers on how to handle these situations if they were to encounter them?
For the most part, it was a confluence of kind of two patients in one with the burn and the overdose. And it was just, for me, is what you're looking at matching the picture that you have in your head, that you, okay, like this was the description of my patient. I have a burn patient. Okay, I've got a burn patient getting bagged on the floor. Okay, am I working a code? No. Okay, then why is he unconscious for me? Was he beaten? You know, that kind of thing. So you're looking for trauma, overdose, low BGL. The guys had checked the BGL before I got there. You know, all those different little things make sure that, you know, what you're seeing makes sense. This is the best way I can put it.
That's a great point. Even not the dramatic case of an actual fire in the vehicle, but now that knowing we have folks who are living out of their vehicles, often cooking within them, like the potential for CO, and just that being something to rule out if you come across an unconscious patient that's in their makeshift home, for lack of a better word.
Absolutely. These toxic inhalations can absolutely cause, just added to your list of altered mental status and things to consider and think about. Especially as we're getting into the winter season now. This is the time of year when we see more of it.
Awesome. Thank you, Chuck. I appreciate you coming to talk with us about this case. It was fantastic. That's all we have for today. If there's any other interesting cases that you want to bring, contact any one of us. Contact your 7A. You can use the SharePoint tab. And until then, we'll see you next time. Thanks.